everybody to our monthly session. And thank you for being here. Thank you, Dr. Ramya, for doing this. So Dr. Ramya is our expert neuromuscular speaker from the Dubowitz Neuromuscular Center from Great Ormond Street in London. And she's in the middle of her work day. Yes, but at the middle of your work day, no? It's still, what is it, 3 o'clock, 3:30, 4 o'clock?
3 o'clock.
Okay, so we got this next 2 months, we got a spate of British speakers. Next month is going to be Dr. Sitara Ramdas from Oxford, from the Strong Center, from Lawrence Service Center in Oxford, Translation Research Center. Sitara Ramdas is going to be speaking about newer genes in congenital myasthenia. So today, Dr. Ramya has been involved with a lot of work with the preliminary studies that's been happening with advancements that are coming in the field of LAMA2. So more about clinical guidelines on how to manage these children, because we know the natural history well. So can we manage them well, disease modify them and keep them in good conditions so that when research becomes available, they are able to better make use of it. So thank you, ORDI, for providing this platform. And thank you to Dr. Ramya, Dr. Himashweta, who's a pediatric neurology fellow and neuromuscular fellow who works at Bangalore Baptist Hospital at my center and in St. John's. And to Dr. Saravanan, who's a cardiologist who's been bearing with us for quite a while and sees a large chunk of our neuromuscular patients. So on to you, Dr. Himashweta.
Yeah, yes, ma'am. Just 1 second, I'll just try to share my screen. And just 1 second. Is this visible? Is my slideshow visible?
Somebody from Great Ormond Street.
Yes, your slideshow.
Yeah. So good evening, everyone. Today I'm going to present a few cases that we have regarding LAMA2-related muscular dystrophy. So a very brief session. Sorry, I'll just reshare it. I'm just stopping to share for 1 second. Ma'am, there is a little bit of presentation problem from my slide. Just give me 1 minute. Restart. I'm unable to share my this thing for 1 second. I'll just.
Do you want me to try sharing the screen?
Yes, that would be great, ma'am.
Because you are the host at the moment.
Yeah, I'm just trying to. Just give me 1 minute. I'll just try to do that again.
Do you want me to give me the host credentials so that I can mute and silence as and when?
Yes, I will do that.
Because when you're a speaker, you might not be able to pay attention to it.
Yeah. Just 1 second. So, I am the host now. Yeah, now it's make host. I have made you the host, ma'am.
I'm the host now.
Yeah.
Okay. Yeah, I can do that. Yeah, sure. So now tell me if you want me to present.
If it's possible, that would be great.
Absolutely possible.
Yeah.
Okay. Can you see the screen?
Yeah, I can.
Because I've got everybody talks.
That's great. That's great. Okay. So, yeah. So we can go to the next slide. Yeah. So case number 1 is a 4-month-old boy who presented to us with reduced movement in all 4 limbs, onset from 2 months of age, and the onset was antenatal with oligohydramnios and intrauterine growth restriction, which was noted on the antenatal USGs. On retrospective history taking, we could find that on the history. On further history, we could find that the child had feeding difficulty starting from birth and bulbar weakness was present. Later on eliciting the family history, we came to know that the child had a previous sibling death at 15 years of age from a similar illness. So we found out the detailed family history, and although they were non-consanguineous, they were belonging to an endogamous community, and we found out the records from the previous sibling, which showed us that on the clinical exome that the child had gotten evaluated for, which analyzes 90 genes as a clinical exome panel, the child had the older sibling had a compound heterozygous mutation in the LAMA2, and both of the mutations were classified as pathogenic individually. They went for a parental segregation at that point as well. And both the parents were carriers. Later on, when we did the sibling test for the same uh, mutation, the child came to be carrying both the compound heterozygous mutations for the LAMA2, similar to the sibling. So, when we evaluated the older siblings' record, the CPK level was 1789, and older siblings' muscle biopsy showed merosin deficiency on immunohistochemistry. And although we don't have the muscle biopsy pictures from that slide, we do have a pictures that we found from similar articles adapted for fibrogenesis in LAMA2, which showed pathologically, histopathology showed muscular dystrophy and fiber size variation, fibrofatty infiltration, and uh, on the immunohistochemistry, there was loss of expression of merosin and preserved expression of col6A1 and alpha cytoglycans. On examination of our current case, we found that the child had hypotonia, subgravity power in all four limbs, absent deep tendon reflexes, contractures in bilateral tendoachilles, bilateral pronatus, and finger flexors. There was spine rigidity with the spine expansion to only 1.5 centimeter when we tried to expand the spine. And so then we went for further evaluation for the child. So since the child presented to us at 4 months and the diagnosis was confirmed, we planned for later on review with neuroimaging after the first birthday, uh, ideally, and cardiac surveillance with the help of echo GLS and Holter, because in LAMA2, there is a very common occurrence of arrhythmias and very rarely cardiac involvement in form of fibrosis as well. So uh, now we move on to our second case, which is a 6-year-old boy who presented with motor delay and weakness. The onset of motor delay was at 12 to 18 months, and the child was unable to sit when he presented to us. So, when we evaluated the history further, the child had recurrent lower respiratory infections starting from before 1 year of age, with 5 to 6 hospitalizations per year, and multiple times the child was ventilated as well. So, on evaluating further, the child had uh, multiple joint contractures and uh, epilepsy at onset at 5 years of age. And on examination, we could find proximal weakness, hypotonia, and absent DTRs. We could note contractures in bilateral tendoachilles, long finger flexors, pronatus, and some hamstring tightness as well. And scoliosis, which we had noted was very mild, thoracolumbar right convex, but it was not noted previously by the family. So when we took the family history, there was a history of consanguinity in the family, and this was their only child. So then we evaluated further with CPK levels 1227. MRI brain showed how white matter hyperintensities, which spared the corpus callosum, and query leukodystrophy was there. In some of the cases, there is corpus callosum dysgenesis or agenesis as well, and thin corpus callosum, which is a differential for many other mitochondrial diseases as well. But in this case, along with some other cases, we could find some corpus callosal involvement. On muscle biopsy, which was done, it showed congenital muscular dystrophy, but remarkably, the IHC did not show any deficiency of merosin and alpha dystroglycan. Since there was suspicion, we went for electrophysiological studies as well, which showed axonal motor neuropathy in bilateral ulnar, common peroneal nerve, and right peroneal nerve. So this is the MRI of the child which we had noted, which was done previously at 9 months of age, and it shows white matter intensities, leukodystrophy, which we can note. So moving on for further workup and management, we did genetics whole exome, which showed LAMA2 exon 9 homozygous mutation, which was classified as pathogenic. Parental segregation showed both the parents being heterozygous carriers for the same. And we evaluated with functional studies of Echo plus GLS, which showed GLS of -14 on serial 2 scans. The first scan at 6 years being normal, the second one at 7 years showing GLS decline of 4%. Initially, it was 18%, and then it showed 14%. So the child was started on prophylaxis with perindopril and eplerenone. Holter was suggestive of sinus tachycardia and nocturnal sinus bradycardia. So the child was started on carvedilol prophylaxis, and since the history of there is a history of frequent respiratory infections as well. So we did a BiPAP which showed sleep hypoventilation, and the DEXA scan showed osteoporosis because LS spine was -1.5, but the left femur was -6. So along with vitamin D prophylaxis started on biannual bisphosphonate and serial monitoring for the bone health. So our last case for the day, very brief. This is a child which is on regular follow-up with us right now. It's a 6-year-old girl who presented to us with proximal weakness and floppiness, onset at 3 months of age, and there was some IUGR in the mother, but although not well documented. So the child presented with proximal weakness, but there was also a background of frequent low respiratory infections and sleep hyperventilation, which was detected on the sleep study. Uh, uh, Failure to thrive, the child weighs at 9 years right now, the child weighs just 20 kgs, and contractures multiple in lower limbs as well as upper limbs, and scoliosis, which is very mild and well controlled on conservative management as present. Child was very dysmorphic with long triangular faces, high arched palate, and cognition was well preserved. So, investigations and interventions for this child in brief: MRI brain done at 9 months showed white matter changes, although not as much as the previous case, which we could show since it's a spectrum. Genetics showed LAMA2 compound heterozygous mutation. The parents are not consanguineous, neither they are endogamous. But on parental segregation, both parents were carriers. Cardiac workup showed normal echo, GLS, and normal Holter, which is following up at least annually. Sleep study suggestive of sleep hypoventilation. So she was initiated on nocturnal BiPAP since 6 years of age. And DEXA scan was suggestive of osteoporosis starting as early as 6 years. So right now she is on bisphosphonate maintenance dose. So yes, this is a little bit brief of 3 cases showing a sort of spectrum. So yeah, Dr. Sarvanan and Dr. Ramya will discuss further. Yeah, thank you.
Dr. Saravanan is going to take a little time. So on to you, Dr. Ramya, the next speaker.
Yeah, I'm just trying to share my screen. Can you see my presentation?
Yeah, it's visible, but it's on the thank you slide.
Yeah, sorry. I'm just going back. Okay. Can you see now?
Yeah, visible.
Okay. Yeah. So thank you very much, and I think Himshweta has already done half of my job. She's kind of touched upon everything. I think I'm just going to add very little to what has already been discussed now. So the reason I wanted to do this is because there's a new care guidelines that has been that is out in 2025 in January, and I think the reason that all the care guidelines are coming up now, and this is being seriously taken into consideration, is because of a lot of therapies which are promising and in the pipeline. So I think there are ASOs, gene therapies, all of these things happening. So whenever we have got these promising therapies in preclinical development, and that makes us understand that we need to be more trial ready whenever this hits the research platform. So for that, the basic need is to understand the natural history of the disease, and we need to have proper, we need to reflect on where we stand, what else needs to be done. So identification and validation of outcome measures is very important. And then standardization and optimization of the clinical care to understand where there are gaps and how are we going to come up with consensus of guidelines to manage those challenging situations. So as I previously mentioned, this is the paper on the 283rd NMC International Workshop about LAMA2 ORDI clinical guidelines and recommendations. It's a very nice paper, and I have just tried to summarize the important things that we should probably keep in our mind whenever we see patients with LAMA2-related dystrophy. So this workshop had around 21 scientists and clinicians. There were 2 patient advocates and also 1 individual affected with LAMA2-related dystrophy, and they were across 10 countries. And it happened in Hoofddorp in the Netherlands last year in January. So just quickly to touch upon disease overview and diagnosis. So LAMA2-related dystrophies are caused by biallelic pathogenic variants in the LAMA2 gene. And we can have 2 phenotypes. One is the CMD phenotype, and the other is the LGMD phenotype. So the congenital muscular dystrophy phenotype is more severe on the spectrum, where you can have infants, as Himshweta showed in one of the cases, very early presentation. They can have facial weakness, axial weakness, proximal weakness, and very importantly, the upper limb is more weak than the lower limb. They can have very early onset of contractures, again more pronounced in the upper limb, scoliosis, and we'll go through all of these things in the upcoming slides as well. And they also have a very exaggerated or hyperlordosis, and less than 10% of them in the CMD phenotype achieve independent walking, and they also have significant respiratory and feeding difficulties. Now, coming to the LGMD phenotype, they are more milder, either it is childhood onset or they are adulthood onset. Apart from these, we can have certain atypical features or additional features like tongue hypertrophy, ophthalmoplegia, and then you can have, as we saw in one of the cases presented by Himshweta, they can have white matter abnormalities, cortical or brain malformations, and 30 to 40% of these patients develop seizures. So this is one of the muscular dystrophies where you may not have a lot of muscular symptoms setting in or presenting, but could present to a pediatric neurologist just with the seizures, and then you go around, do an MRI, there's lots of white matter changes, and then moving forwards, they kind of develop hypotonia and have progressive weakness. So this is just taken this picture from one of the articles. I found it quite useful because this one picture gives us a lot of the clinical presentation. If you see, there is a lot of facial weakness, difficulty to close the eyes, and then there is a bit of midfacial hypoplasia. Again, facial weakness is quite evident here. And also, very importantly, which we don't, I think, not very much give importance to, is the malocclusion and the issue with large tongue. So this is also one of the phenotype, and we'll talk about how these become very important in their management. And then if you can see, they have got the hyperlordosis, and the cervical spine lordosis can be there. Then you can have scoliosis. And then this is a picture showing either they can have wasting, or there's a very small group that can have some hypertrophy as well. Now, this kind of picture shows where the weakness is maximum. So if you see, there's a lot of weakness around the shoulder blade. The upper limb muscles are quite 4 to 5 degree MRC grading, and then in the lower limb as well, with the foot as well as the thighs, there is around 4 to 5 MRC grade weakness in the hamstrings as well as in the leg muscles. So coming to the pathomechanisms and its implication for care management. So we know this is not a disease that affects only the muscles. It's a multi-organ disease affecting skeletal muscle, peripheral nerves, and brain. So if we look at laminin, the disease is caused by mutations in the alpha subunit of the laminin. So this laminin protein, or laminin 211, is something that connects the extracellular matrix with the alpha dystroglycan complex, which is which we are all aware of is a muscle membrane complex. So it is like a connection between the extracellular matrix and the muscle membrane, and any mutations in this can disrupt the subunit of the alpha 211. And now this is kind of expressed in it interacts with various proteins in the muscle. It's with alpha dystroglycan, whereas in the nerves it interacts with integrin alpha 6 beta 1 and GPR 126. So that is the reason that you see the expression even in peripheral nerves, and there is changes on the electrophysiology or the neurophysiology as well. So coming to the diagnostic approach, the first tier test is going to be full gene sequencing, either by Sanger or the next generation sequencing. So in LAMA2, the most of the variants reported are in the coding sequence. So the NGS should be able to pick it up, whereas the copy number variants and intronic variants are very less common among LAMA2 RDs. So whenever we are having a very high clinical suspicion of LAMA2, I mean, the phenotype is fitting, but the genetics is negative, then that should probably prompt us to do more deeper dive into the genetics. So and look at LAMA2 dosage and intronic gene variant, intronic region analysis, especially when we have a proven laminin 211 deficiency, but negative coding sequence variants. So in case we have a variant of unknown significance in LAMA2, so the next step would be to go for RNA sequencing if there's if we're thinking more of a deep intronic variant, or it is a long read whole genome sequencing, which is more good at picking up structural variants. The RT-PCR on the peripheral blood is not found to be very useful whenever we have variants of unknown significance, because it will not help us predict the impact on the splicing. Now, when it comes to those with very milder phenotypes, where they just have a bit of, white matter changes, or they have peripheral nerve involvement, but not of muscular features, then that in that cohort, which have very mild phenotype, very mild muscle involvement, and we are trying to prove a LAMA2-RD, but the genetics is not picking up anything, that is a bit of a diagnostic challenge. Coming to the cardiac care, there were two papers that is one by Sproyu and et al., where published in 1998, where they had 16 LAMA2-related muscular dystrophy patients, and the average ejection fraction in them was around 43%. And there was another paper in 2000, again, which showed some ECG abnormalities, including a right bundle branch block pattern and dilated cardiomyopathy, but borderline cardiac function changes. Now, based on all of these things and the key agreements from the working group was that cardiac involvement is prominent more after the third decade of life, and then we need an annual cardiac assessment with ECG, echocardiography, and Holter. That is the recommendation. And then we can consider early pharmacological intervention with ACE inhibitors, beta blockers, and aldosterone inhibitors. But there is no role or evidence to justify preventive management currently. So coming to the respiratory care, which is, I think, one of the most important domains to be addressed in LAMA2-related muscular dystrophy. So because this is a condition where they develop early contractures, especially the CMD phenotype, they have a lot of contractures. They can have neck muscle contractures, elbow contractures, finger contractures, and even the chest wall is a very restrictive chest wall physiology. So all of these things are going to contribute to a smaller chest wall, decreased lung volume, and then progression of hypoventilation. Now, apart from all of these things, they can have ENT problems, like you can have a macroglossia, again, that can add to the obstructive component of the sleep hypoventilation. They have mid-phase hypoplasia and malocclusion, and a bit of neck rigidity as well, as I mentioned, due to the contractures. And all of these things will make it a bit more challenging, especially if we have to tube them in an acute situation. So this is something to keep in mind, especially when we have discussions with the PICU team, to alert them that this could be a tricky intubation or a difficult airway. Now, again, because they've got an open bite and a big tongue and facial weakness, doing PFTs and interpreting those results and considering them as a way of monitoring the respiratory status or progression of respiratory weakness should always be done with caution, because they are not going to be very, very reliable. And they, as such, in the very weak ones, have a restrictive thoracic defect. So the PFTs could be a challenge in this cohort of patients. Again, scoliosis, they do develop scoliosis, which will affect the lung volumes. Now, in the paper, they have described from one of the discussions from Dr. Regan Foley, based at NIH. So they've described there can be two phases of respiratory decline in this cohort. One is around 24 months of age, when that is around the time that they will need establishment of the NIV. That is one phase where they can come with a respiratory failure, and that's how it's picked up and they start on NIV. And then moving forwards, as there is progression of muscle weakness at around 12 years of age, there's another phase where they can have a steep respiratory decline. And this is purely because of the disease progression and worsening muscle weakness. So the key agreements on the respiratory care was we should have early assessment of the restrictive chest wall deformities and also look for actively any symptoms of hypoventilation. The best way to check this would be polysomnography or sleep studies, and it should be done at the time of diagnosis, not based on the symptoms. It should be done at the time of diagnosis, and then every 12 to 8 monthly. Again, the threshold can be much lower if we can bring it down to 12 months from 18 months if we think there is a lot of issues with weight gain, symptoms of sleep hypoventilation. So we should have a really very low threshold to subject this kids, especially from the CMD phenotype, to sleep studies early on. They do advise us to do annual PFTs. And then the other important topic that they touched upon was using in an exafflators, that is your cough assessment machines, is for secretion clearance, and they should be used daily. Also important to reiterate them to have these additional immunizations, like pneumococcal as well as the flu vaccine, because these can really prevent them from going into the ICU, especially during winter seasons. And for those eligible, RSV antibodies can also be considered. Now, in a critical care setting, there are a couple of points that we probably will have to keep in mind when we have a patient or a child with LAMA2-related dystrophy being admitted to the PICU. One is the respiratory failure is going to be the leading cause of morbidity and mortality in this cohort. Second, in the CMD form, the respiratory failure is very common in the first 2 years of life, and that's why we need to very, very closely watch and probably proactively subject them to sleep study to look for sleep hypoventilation and start them on an IV or BiPAP, which is the preferred first line of respiratory support or management in them. Again, invasive mechanical ventilation, we try and avoid. It's the thumb rule for most of our neuromuscular patients. We try and avoid or keep it to the shortest possible duration and minimize that. But the indication for invasive mechanical ventilation in this cohort should be whenever there is a failure of secretion clearance or the airway protection is lost. Again, we should always extubate them onto an IV, and this is going to need a multidisciplinary team approach given the high risk factors. We may need the EMT to help us, as well as input from the respiratory team and the critical care team. Coming to the physical therapy, the goal again is to optimize functional independence. So they can do active or passive stretching, bracing for the scoliosis. For the contractures, we can consider serial casting, and in the non-ambulant group, but who can weight bear, probably we should encourage them to do more of supported standing. But there's no clear evidence of improvement in the functional range of motion with all of these therapies, but it is good in terms of maintaining function. Again, they will require some guidance on seating, especially with wheelchairs, and with the scoliosis progressing, they will need adaptations with the wheelchair, and especially because they've got a very thin, long, and hyperlordosis can extend to the cervical spine. Most of the times, these group of children can have problems with maintaining their head straight for very long time. So it is just not the spine, but sometimes they will need support up until their cervical spine. Coming to bone health, I think this is something which we have learned from the other muscular dystrophies as well. Most importantly, this should be at least initiated if the patient becomes non-ambulant, but it is very good to keep monitoring their vitamin D levels yearly. And then the first line of treatment, in case we find that their bone mineral density is low, is bisphosphonates. Again, we should involve the bone endocrinology team early on in the care and management of low bone mineral density. So this is one of the pictures that I've taken from a paper by Dr. Sarkozy. So if you can see, there is a lot of lordosis. They have a very thin, straight or a long neck, and then they can have rigidity or contractures of the neck as well. And then the hyperlordosis can progress to the thoracic and the lumbar spine as well, apart from the scoliosis. And then they have a lot of contractures in the knee as well as in the elbows. So coming to the management of scoliosis, it's more prominent in the CMD phenotype than the LGMD phenotype. And again, rapid progression in the first decade of life, where you really do not want them to progress to such a level that you will have to subject them to scoliosis surgery or spinal fusion surgery, because that's not the time when we do the spinal fusion. We want to try and prevent scoliosis from rapidly progressing, so that we try and push this to their puberty or until they have achieved a considerable amount of their spinal growth is complete. Hyperlordosis, again, as I mentioned, it can extend up to the cervical spine, and we need to encourage them to have a lot of active movements. Swimming is a very good exercise to help with this, and also do passive stretching. As I mentioned before, spinal surgery is something we should try and delay until their puberty, so that they're not having multiple phased surgery, rather have just one surgery when they hit puberty. From the orthopedic point of view, they do always advise to kind of prefer to use growing rods, which are more suitable than the magic rods for this group of conditions, if they need spinal surgery before puberty. Again, the most important thing to remember, and this has been mentioned multiple times in the paper, and is that to optimize their nutrition before or well in advance, so that their recovery post-operative is going to be quick. If their nutritional status is going to be poor, the recovery is going to be quite delayed, and the outcome of the surgery, there will be a lot of complications in the perioperative period. So coming to mouth, facial weakness, enlarged tongue, and speech ramifications. So these can have an impact on ability to communicate, again, articulation issues, speaking. So this is something that we need to look into from the beginning. Again, because of the facial weakness, big tongue, and then difficulty to close the mouth or malocclusion, all of these things can contribute to chewing and swallowing problems. And this is very important to be addressed because this can lead to less caloric intake and poor weight gain in them. Again, the challenges that they are going to have is the oromotor muscle weakness, hypophonia, abnormal oral structures, as I mentioned, malocclusion, mid-hypoplasia. And because they are using an IV for a very long time, they can have this mid-facial hypoplasia and breath control difficulties. Again, these challenges are going to be even more if there is a presence of tracheostomy. So we should involve our speech and language therapists, ENT team, and the dentist quite early on, so that we can have a discussion about what could be the plan moving forwards. Surgery for macroglossia is currently not advised because we do not have much of evidence on the safety of these surgeries. So there is no current agreement about surgery for the macroglossia. Coming to the feeding and nutrition, I think next to the respiratory care, scoliosis, I would put feeding and nutrition here. Again, as we discussed, all of these things are going to contribute to less caloric intake and poor weight gain. So sometimes it's the lack of appetite and early satiety. These are the factors that should kind of ring a bell to say, okay, this child is going to need a bit more of nutritional support now. Again, the decision about gastrostomy should be quite early on if needed. But in the paper, they mentioned that most of the times this was prompted only before the scoliosis surgery, because they wanted to maximize their nutritional status for the optimal recovery. So it was planned quite close to the upcoming scoliosis surgery. Now, I will talk about this a bit more in my next slide, about the episodes of hypoglycemia, and we'll address this next. So again, one thing to remember is if we are using their BMI as one of the parameters to look at their growth or weight and height, is not something that is very reliable in this group of children, because we cannot always get a right measure of their height because of the contractures and the scoliosis. So in which case we should use their ulnar length to calculate their height, to calculate their BMI, and not use their height because it can be inaccurate. Again, the indications for gastrostomy in this group should be if there is a growth stagnation, if there are any hypoglycemic episodes, or if we think they're going for a scoliosis surgery, we should offer them as a short-term gastrostomy for a perioperative nutritional support and speed up their recovery. So hypoglycemia in LAMA2-RD, this occurs due to the reduced muscle mass atrophy and limited glycogen storage. So the risk group is those who are less than 10 years of age, who have very low body weight, especially also in non-ambulant group, and among those who have significant swallowing difficulties and are not PEG-fed. So some of the risk factors that they've mentioned here is the severe motor impairment, and then if they're dependent on an IV, and they have a very low neuromuscular disease swallowing status scale scores, and the presence of loss of function LAMA2 variants. These were some of the risk factors that were found in those who have a lot of muscle wasting and are at a risk of hypoglycemia. They found that once they had these gastrostomy, the hypoglycemic episodes got better. And in LAMA2-related dystrophy group, it is important for us to differentiate if they have a seizure, is it due to the brain involvement and it's epileptic in nature, or is it an hypoglycemic seizure? So we should always, like we do, always check a sugar in them if they happen to have a seizure. So again, we should advise the parents to have this sugars checked if they have any symptoms of hypoglycemia in the kid, especially more so during illness or in the perioperative period, or if it's after a trauma or a surgery. And then they should have an appropriate nutritional advice and a management protocol of their hypoglycemia, and also low threshold for a gastrostomy or an NG tube feeding if they have encountered hypoglycemic episodes. Coming to brain in LAMA2-related muscular dystrophy, I think Himshweta has already touched upon a lot of these. They can have these white matter changes, and they can have causing it motor impairment. They can have cortical malformations like polymicrogyria. They can have occipital FCDs, brainstem hypoplasia, and cerebellar hypoplasias. Again, epilepsy, they can have either focal or generalized or absent seizures, and most of them, around 50% of them, are said to be drug responsive, and very rarely they are drug resistant. They can have cognitive difficulties, which may warrant them to have some neuropsychological assessments. They can have these abnormal white matter changes. Now, these white matter abnormalities can be present in as early as 6 months of age, or even in a 1-month-old infant, even before they have had any kind of a muscle weakness or hypotonia manifesting. So we mentioned that these cortical malformations, have spoken about that, and the first line of anti-seizure medications they've used is valproic acid in most of the cohort. Again, the recommendations from the working group was that if we are having any concerns about neurodevelopmental concerns in them, all of them should have a 3 Tesla brain MRI. And then there is still a need for consensus about early diagnosis and management. There is no written consensus on the management of seizures in this cohort. But for now, they will need a 3 Tesla MRI and if we have got concerns about their neurodevelopment. Neuropsychology in LAMA2-RD, there's a very large range of cognitive function that is reported in this cohort. So the correlation between the cognitive function, the brain malformations is not clear, but the cognitive issues were found to be more prevalent in those who had either epilepsy with LAMA2-related muscular dystrophy or they had any brain malformations. So there is a need to explore this particular aspect in larger cohort of this category. Again, neurocognitive assessment in those with academic concerns or at onset of seizures will be important. And then we should have a slightly higher threshold, especially if they mention to us during the consultation about concerns with attention and executive functions. So the other aspect was about peripheral neuropathy. This will be the last aspect. So the laminin-211 protein is sorry, I think it is, I didn't mean less crucial, has a crucial role to play in Schwann cell axon interactions, and it influences the myelin formation as well as the nerve regeneration. That's the reason it's expressed in the nerve. Peripheral nerves as well. Now, the nerve involvement again can be as early as 1 to 6 months of age, and it can be unrelated to the muscular phenotype. But the NCS and EMG can show either mild to moderate sensory motor demyelinating neuropathy with reduced conduction velocities and CMAPs. So this is something we would find. But again, the prevalence of peripheral neuropathy in LAMA2-related dystrophy is not known. And currently, there is no recommendation that all of these patients need to routinely have a nerve conduction studied. So there is no recommendations about that. Probably this will be very useful in terms of diagnosis when about a child with a congenital muscular dystrophy, where we are trying to look at what this muscular dystrophy could likely be. So this will be one of the clues. Now, in the paper that mentioned, or probably this figure is infographic is quite useful. Just tells us about what are all the aspects that need to be looked into in those with LAMA2-related dystrophy, either the CMD or the LGMD phenotype, and about the genetics when we need to do muscle biopsies, and then about the brain MRI imaging. Yeah, I think that is pretty much from my side.
Thank you. That was a very comprehensive overview of the guidelines, some of which we intuitively know, and we're sort of growing and applying what we know from other muscular dystrophies. So our last speaker for the day is, was there anything about the newer molecules or anything else?
So the current guidelines, they have not mentioned about the newer molecules, but the Europe LAMA2, if we just go upon the Europe LAMA2 page, there is a German group working on gene therapy. There is a Modalis Pharmaceuticals, and then there is one from the NIH group about antisense oligonucleotides. So all of these fundings and all have happened in the last couple of years. So I think there is a lot of hope on all of those things. But I think they do not have very much of a functional outcome measures like we have in DMD and things like that. That is also not something that was touched upon in this paper.
No, that's because of the spectrum.
Yeah.
Yeah, that's probably because of the spectrum. So with SMA1 and 2 and 3, you have that, one has to have this much. This is the phenotype. This is what they can do at different times. LAMA2 is just a spectrum where do you start measuring? Where are objective scores and scales? So it's going to be a bit challenging based on that. And also you have biallelic agreed, but you've got, we have some geneticists in the group. So we could have this discussion a bit later. I'm waiting for Dr. Saravanan to join. Dr. Saravanan is our cardiologist who's seen the maximum number of cardiac.
Yeah, I'm online.
Okay.
I'm online. I'm here.
Do you want me to share your slides?
Yeah, I'm here. I can do. I'll try. I'm very much here. Let me see if I can.
Good to see you from Andhra.
Are you able to see?
Not yet. It's just mirroring the slide. Yes, we can see.
Okay, you can see. Great. Okay, now I'm going to go on. Can you see that?
Yeah, can see it.
Great. Okay, thanks.
Yeah.
Okay, thank you for inviting me to this very eminent group of neurologists and geneticists, etc. I am a very simple, basic clinical cardiologist, and I have an interest in neuromuscular dystrophy (NMD) after having had an exposure to work with Dr. Ann, and I've been improving on my skills. So hopefully, I won't bore you too much. I will tell you a little bit about what we do and what I do from an NMD point of view, and we'll discuss about what can be done in our setup actually. So approach to cardiac evaluation of neuromuscular disorders as a general rule, these are the main things. NMD providers should promote education regarding the importance of proactive approach of screening and diagnosis, particularly for cardiovascular complications, because increasingly we are realizing that cardiovascular complications in NMDs are under-recognized, under-reported, and actually are quite prevalent with any neuromuscular disorder. And as we earlier, we thought that it happened in particularly in DMD. We thought only after the second decade, people will develop cardiac disease. But now we know that we have had patients with 2 years who have had LV dysfunction in DMD. So this is an evolving field, and therefore we need to be very aware of it. All neurologists diagnosing and managing NMD should work to identify either a cardiologist with expertise in this area or collaborative electrophysiologist, heart failure specialist, which I believe I am all the three. So therefore, it's something that important to have a good working relationship with somebody who has an interest and does this day in, day out. Like anything else in medicine, repetition improves the outcome and improves the performance. So it's all about volumes. So how often we do something, and I'll show you that in an example in an echocardiogram where my technician does an assessment in practically 2 minutes when she knew nothing about this when she started with me 2.5 years ago. So cardiac evaluation should be performed before anesthesia or sedation in patients with NMD with cardiac risk. Such evaluation should be done in close proximity to the anesthesia event. It's something that's advisable. This is also another advisory. So for NMD patients at increased risk of cardiac during surgery, a team approach. And we have had a couple of situations where patients suddenly deteriorated from a cardiac function around surgery, particularly spinal surgery. And Dr. Ann knows about these two patients. And it is important to remember and know that patients can suddenly have acute cardiac deterioration, a bit like myocarditis type picture, but it's actually myocardial ischemia that causes that. And it's very important to understand that as well, that they can develop this around surgery, and therefore the risk of surgery, not only pulmonary side, but also cardiac side, is high for these patients. This is I think this is a chart that's taken out of a previous summary statement on NMDs. And so there's lots of things. What was previously classified as LGMD has now become, as you guys know better than me, has become more refined and more clearly classified. And one of the things is what we're talking about today. So it's important to note that various NMDs have various degrees of cardiac involvement, and in that there are 3 particular components. And the reason why I show this is mainly that cardiomyopathy, arrhythmia, conduction disturbances. These are the 3 main things that we are looking at in this situation in patients with NMD. So any one of them can predominate. In certain situations, it could be all. And very recently, we are noticing there are a number of reports of sudden cardiac death in patients with NMD, particularly in the type of NMD that we are discussing today. So it's important to be aware of these cardiac complications in these patients so that you can identify early. This is very similar to the previous slide, so I will skip this. Heart disease and NMD epidemiology. Historically, the cause of death has been respiratory failure, but with improved respiratory support, all NMD patients are now living into 2nd, 3rd, 4th decade, and therefore it is important to focus on other causes where they develop morbidity as well as mortality, and heart failure and sudden cardiac death is another important area where we need to focus on. The risk of LV dysfunction in all NMDs increases with age. Some of them not so much prevalent as others, and that's what we're looking at. So when we diagnose cardiomyopathy, the standard cardiac imaging, the only way to diagnose cardiomyopathy is to do cardiac imaging. And the standard cardiac imaging, the routine 2D echocardiogram that you can get, conventional 2D echo with fractional shortening and ejection fraction, etc., which is readily available, particularly in India in every street corner, is not necessarily going to be enough. And that's mainly because some of the findings are very subtle early on. And if we identify early on and interfere, we would definitely slow down the progress of the disease. And in that, one of the modern techniques that we use, and we use a lot in our setup, is speckle tracking or strain imaging. And this is very commonly called as GLS. And as you guys know about GLS, the word GLS is something very familiar to all of you. But what that really means is that it is a form of imaging where we are looking not just simply about the contractility of the heart, but deformation of the heart. The heart is not just a simple squeeze in, squeeze out thing. It has actually three components, which is important. So therefore, the contraction, relaxation, and the torsion. So when we look at all of that, we look at it in speckle tracking. The cardiac MRI is gold standard and recommended in most patients when echo is suggestive. The identification of early changes is very important to be able to differentiate. The strain rate imaging in echocardiogram is a method of echocardiography for measuring regional or global deformation of the myocardium. The term deformation refers to the myocardium changing its shape, not just simply squeezing. So it has three components: the longitudinal, circumferential, and the axial. So all of them will deform, or the heart will deform in all these angles. So as you see in this image, the strain imaging in echo causes deformation occurs in the longitudinal, circumferential, as well as the radial direction. And the circumferential and longitudinal are negative, while radial strain is positive. So when all this three deformation is put together, that is when you get the global longitudinal strain imaging, GLS. Okay, so what we get as GLS is the combination of all these three: longitudinal strain, circumferential strain, and the radial strain. Sum of all the deformation along long axis of the LV taken in three different planes gives the average value. This measure is more sensitive than fractional shortening or ejection fraction, and the nomogram differs with each machine and the software package that you're using. New nomogram for Philips uses ACE guidelines, which excludes the apical segment of the heart and therefore only uses the basal segments and has -15 as the normal. -15 in the Philips machines is the normal GLS. Anything more than that, more negative than that, is good. Anything less negative than that is not good. So I'm going to show you an image of this. Is we doing GLS in our lab today, and my technician doing it, and me doing a video. And as you can see, it is a very, very quick and simple process if you know what you're doing. So what she's doing here, she's tracing the endocardium in a 4-chamber view, and then she is feeding it into the computer, the software. The computer is analyzing it. We are checking it, and manually you can modify that. If you think the computer is making a mistake, you can modify that manually, and you can see the end result on that 4-chamber view. Now this is on the 3-chamber view. The same thing is being done on the 3-chamber view. And in the 3-chamber view, again, we are doing the same thing, and you can see that beautifully the endocardium is defined. And then it gives individual GLS or individual GS for each one of them, and then puts all the three of them together as GLS, global longitudinal strain. This is a 2-chamber view. And in the 2-chamber view, you will see that the computer has made an error in that it is coming into the mitral valve, and she has edited that. And finally, you will get a picture like that. So that is what you get, which is 2-chamber, 3-chamber, 4-chamber views. You need to get good images. And once you get good images, then you will only then you can get this kind of appearance. So that the bullseye that you are seeing there will tell you, individual segmental GS, linear strain, longitudinal strain. So based on that, you can even identify which areas are contributing to the reduced. Just one moment. I think it's emergency from the hospital. I had to take this call. Hi, Shashank. Is it important? I'm in the middle of a talk. Is this important? I am in the middle of a talk. Yeah. Okay. Okay. Is there ST elevation? ST suppressed segment depression V5, V6 is not an emergency. Okay, I'll call you back. Thanks. Bye. So I'm so sorry. The bullseye will give you the idea of where the problem is. Not only that there is a problem in the GLS, it will tell us. And in certain conditions, it's in certain parts of the heart, and therefore it's very important that way as well. So this is cardiac MRI. This is standard cardiac MRI imaging. All of you are aware of this black pool imaging, and you know more about MRI than I do. So short axis and long axis cine in the heart, and late gadolinium enhancement and perfusion imaging. These are standard methods of imaging of the heart in MRI scans, which will tell us evidence of fibrosis. There is also a more modern MRI technique, which is exactly the speckle tracking applied in MRI, which is even more sensitive than the GLS that we are doing, which will help us to identify very early changes in patients with neuromuscular disorders. The other thing is about markers, biomarkers. Cardiac troponin T, not troponin I, goes up in neuromuscular diseases. So serial measurement of cardiac troponin T, once you have identified that there is some evidence of LV dysfunction, which is what we do in any neuromuscular disorder, there will be a serial increase in troponin T, which will give us an indirect evidence of the degree of damage that's happening to the myocardium. So therefore, cardiac troponin T is a reasonably good measure once there is some evidence of cardiomyopathy, either by altered GLS or by EF. So now, the LAMA2-related muscular dystrophy, the evidence on LAMA2 muscular dystrophy, particularly in terms of the cardiac involvement, is very, very flimsy, very small amount of data that's out available there. This one paper was looking at a combination of conditions, LAMA2 and selenium-related myopathy. And in that, what they had reported is that there is extensive overview of the cardiac complications in LAMA2. Primary LV dysfunction is frequently reported in LAMA2 muscular dystrophy, contrary to previous belief that LAMA2-MD is not that seriously affecting the heart. This particular study said, no, there is a significant LV systolic dysfunction happening in patients with LAMA2-MD. Secondary RV dysfunction, but not LV dysfunction, was seen in a selenium-related cardiomyopathy.
Sorry, you're not audible, Dr. Saravanan. You're not audible. Dr. Saravanan, your video is gone and you're not audible. Hello? Okay, sure. Thanks, bye. Sorry, Dr. Saravanan just got logged out. He's trying to log back in through his phone. So while they're continuing, so as you can see, the first three, we don't have enough. So he's just logging back in. I'm just sharing his slides meanwhile, just so that you can, because it's only the last few slides. Which one are these? Is this the one, Dr. Saravanan?
Yeah, this one and the next one. Yeah, next one. And the next one. Yeah, this one is the abstract on that one. So this is the paper that I was referring to in there. So what they are saying is they had seen over a 1.5-year follow-up, one of the 7 patients developing significant LV, worsening of the LV dysfunction. So that once LV dysfunction sets in LAMA2 muscular dystrophy, it does tend to progress fairly rapidly, and therefore it is important to keep an eye on that, is something that this particular paper is referring to. And the last couple of slides I want to show is the position statement there on the workshop that already has been referred to in a number of different talks, I think, today. So this is the latest on the January 2025 Dutch statement on LAMA2-MD. And in this, I'm specifically taking out the cardiac status. And if you read the small print here, you will realize that there is absolutely no clarity on what is actually currently known or what is currently the main concern. And in that, what they're saying is that the pharmacological approaches like beta blockers, there's not very little evidence for beta blockers, ACE inhibitors, aldosterone inhibitors, or SGLT2 inhibitors, all the heart failure therapy. But they're saying if these patients develop this, then you could possibly use any one of these or all of these medications. Most important concern here is that we need to start therapy early, but there is no consensus on starting it as a prophylaxis. There is absolutely no evidence for that, no consensus for starting therapy as a prophylaxis, as opposed to some other NMDs like DMD. So here, the advisory, the key agreement is that the group agreed that annual cardiac assessment, including ECG, echocardiography, and Holter, should be standard practice for LAMA2-related cardiac dystrophy, muscular dystrophy. Further research is needed, obviously. And ACE inhibitors, beta blockers, and potentially aldosterone inhibitors may be useful once cardiac involvement is established. The role of preventative therapy is not clear, and it is important to manage the patients in an expectant thing. And that actually you need to, in view of the concerns or reports of sudden unexplained death in LAMA2-RD patients, it's important to anticipate and expect problems. And one way of looking at it is to look at the ECG fragmentation. So my suggestion for practice protocol is that any patient with LAMA2-MD at diagnosis should have a 12-lead ECG, a 2D echo with GLS assessment, as I mentioned, a 3-day Holter study, and baseline biomarkers, troponin T, NT-proBNP, CK-MB. We don't know what of these is going to be elevated in this condition because there's no data for that, but it's good to have a baseline value on all of this. After that first visit, I would suggest annual review till the age of 17. And because at 17, previously it's been recorded that the incidence of LV dysfunction becomes more likely. So after 17, a 6-monthly review if cardiomyopathy is suggested in imaging, but no actual LVST and no actual LV dysfunction. And 3-monthly review if there is actual LV dysfunction, because of the fact that in the LAMA2-MD, once LV dysfunction sets in, it seems to progress fairly rapidly. Thank you. Thank you. That's my last slide, and this is where we do our work. And Dr. Ann and I, we work in that center. So it's Dr. Ann's center, which is Virgo, and I do my cardiac practice there. Thank you.
It's our center. So thank you so much, Dr. Sarunan, for that good, concise overview of the cardiac care of these difficult conditions. As you mentioned earlier, that paper that was presented was of 7. We have around about 10 to 15 children that is there. We just chose to take 3, and of the 3 that we picked up, 1 had trailing cardiac issues, which we intervened along the same lines, guessing and just extrapolating ACE inhibitors, eplerenone, and beta blocker. So the floor is open to the attendees, because many of our attendees are quite eminent. Some are scientists, some are prominent geneticists. Dr. Ratna, Dr. Raghavan, anybody else? Anyone wants to make a comment? Dr. Smilu, Dr. Anand Iyer? If anybody wants to make a comment or questions or anything else? We were just talking, Dr. Smilu, Dr. Ramya, we were talking about the possibilities of AON, antisense oligonucleotides, and gene therapy. Dr. Ratna, would you want to comment on anything?
Hi. Thank you so much for excellent cases as well as both the talks. Thanks so much to the speakers and you, Anne, for taking it forward. So I had just one thing. In the era when we didn't have NGS, it's a big gene. and you needed to provide prenatal diagnosis because it's a recessive disorder. So on the muscle biopsy, you would look at the merosin stain. I know this because we learned it at AIMS, and we came back and started doing it. And then on the skin biopsy also, because we were doing the same thing on chorionic villus sampling. You can do the merosin immunostaining on a CVS sample. And so if
On
the
a what sample?
fetus,
On a?
for prenatal diagnosis, the chorionic villus sample,
So
the
who
villi,
did
the
the
chorionic villi.
who had the monoclonal antibody for the
We
medicine?
have it. We had.
Oh, you
We
have
had.
it.
We got
Oh.
it. Yeah.
Okay.
And so that's how it was done. It was
Okay.
much later. And then you could also do linkage analysis. But to do linkage for prenatal testing, you had to be very certain of the diagnosis. And so while the presence of an MRI with this sort of a phenotype is, does suggest this and not too many other differentials, but before doing prenatal testing, this was a step that was done. And this also becomes now a useful step for variants of uncertain significance, where the gene has been scanned well, and you know that this could be a variant because it serves as a surrogate function. Not even a surrogate, it is a functional sort of a test because you're testing the protein.
Okay.
For us to do an RNA, you'd need a muscle biopsy. Am I right, Dr. Ramya?
Yeah.
So that becomes a challenge, and accessing RNA testing, etc., is not very easy. And therefore, this is it's an easier bedside sort of a thing.
That's from a geneticist perspective when you're dealing with antenatal. How do we deal with patients, proband?
You have to first confirm the diagnosis in the proband.
So no, I mean
now
clinically. So
it's
clinically
not
it fits.
difficult.
So clinically
it fits. Now you do the mutation testing.
With the mutation testing, one of the children that we presented had on muscle biopsy, merosin was present.
Yeah, I know. I did see that.
Yeah.
So there are 2-3 things. I mean, there are 2 things I would think there. What is the nature of the gene change? The phenotype
loss
of that
function.
child,
Okay.
And, is it a mild? Will it cause severe protein? Because the amount of protein is dependent upon that.
Yeah, because it's not really exactly quantitative test, the presence of or absence of immunohistochemistry.
No.
Yeah, okay.
For the severe ones, it's actually absent.
Completely absent. Yeah. Okay, because for us, it's slightly easier because we are seeing the severe ones because we are seeing children and infants. We are seeing very few. So when I looked at our database, we don't have anybody with LGMD. That doesn't mean it's not there out to detect. We are seeing primarily the CMDs.
Yeah.
And you're probably seeing also the worse ones, antenatal.
We are also seeing the severe ones.
Yeah.
And yeah, that's true. So what I really wanted to reach out to everybody here is one of my students who's also on this seminar, Dr. Annie Jude, is her thesis work is on the clinical phenotype of LAMA2 muscular dystrophy children.
Okay.
And so we can, share the details. And children who are very far away, we don't need to see it as long as, the phenotype is correct and it's good. And so it would be nice to work together towards that.
Yeah, it would be good.
Yeah.
Yeah,
I'll talk separately with you, and you can
Sure.
also rope in your colleagues there. Thank you.
And our physiotherapy colleagues are very eagerly attending the talk, mainly because they're used to measuring. So the swallowing difficulty, interestingly, one of the children that we followed up for a long time, we saw her yesterday in clinic and we told her, look, we're going to doing a talk tomorrow on LAMA2. So the parents are very proactive. And I think she needs a gastrostomy. It's interesting in Dr. Ramya's talk that she said gastrostomy is often done with the spine, scoliosis, because we cannot convince them. She's clever, articulate, and she's not going to want a gastrostomy. So I've sent her. She's had a barium swallow which showed a dilated esophagus. She's on, PPIs and some prokinetics. But I've just sent her for a VFSS in the hopes that that it'll show something that there's fatigable swallow. Her weight is static around 20, but it's a task going to convince them to do it. Her scoliosis is static. It's not getting worse over the last 4 years. So yeah, so it is a bit tricky. Somebody's raised a hand. Dr. Raghav, would you like to add something? Dr. Raghav, please unmute yourself.
And I'm calling from Madurai. Hello?
Hello, Dr. Raghav.
Hi.
Dr. Raghav?
Can you hear me?
Dr. Raghav?
Actually,
Yes, we can hear you.
there's a confusion. There are two Raghavs over here, and we are not doctors.
I think so.
Yeah.
So this is meant for a physician's thing. Dr. Raghavan is speaking or Mr. Raghav is
Yes,
speaking?
yes. I'm speaking. I'm from Madurai. I have a question for Saravanan.
Yeah, please say.
Okay. My question is that what is the role of what he thinks is the role for EECP when all the medications are given up?
Oh, you mean
I
in
have
cardiac failure?
in failure, the enhanced external counter pulsation, EECP.
Okay. I think Dr. Saravanan has left.
Okay.
I will just try to call, but that because so I can try and extrapolate what we know from other muscular dystrophies because we know
Right.
that when we're trying to do the cardiac MRI, we are trying to see it is the full luminal thickness, full wall thickness involvement of scarring.
Okay.
What we are hoping for many of our children when we are doing the GLS, we also do MRIs, cardiac MRI to correlate. So many of them, it
Okay.
is not intramural. It's only partial mural.
Okay. So
Partial
that's a
mural.
limitation.
Yeah. So then there is role for us as neuromuscular specialists to prevent. Once it's a full wall thickness involved, it's in the domain of failure treatment.
Mm.
So whatever they're doing, it's the same as it's burnt out tissue.
Okay.
So as
Got it.
Dr. Saravanan, as a cardiac failure specialist, would then handle it like he would do with any burnt out tissue.
Mm.
We are hoping to avoid that. We just don't know because it's an unpredictable nature. Dr. Puri was also mentioning that it's based on loss of function. How much of the protein is missing, we are not able to predict. So, if, for example, in DMD, recently I remember our cardiac care has improved so much for DMD that children now live longer. But last year, Dr. Ramya was also there when we were in Vienna. In the cardiac DMD-CM, cardiomyopathy talk, in the discussion we were having, there was a youngest child from Denmark who died at 6 years of age in his sleep
No,
with a
good.
normal
Okay.
echo. So that's rhythm. So you've got both rhythm and normality, and you've got intramural thickness, the entire wall thickness. The entire wall thickness we can do something about. The arrhythmia part, there's very little other than doing a halter. What can we do?
Yeah. Correct. Because I had a 17-year-old recently had EECP done from Patna, and they claimed to be having improved cardiac output, but I couldn't get any because my cardiology understanding is very limited. So I just wanted an opinion from what Saravanan thought about it. So
I can only say, extrapolate and say many of our children, when they're very sick and in extremis, when they're admitted to hospital, their EF, because the windows are not great. They have crowded ribs. Windows are
yeah,
not great. Dr. Ratna, would you agree with me? Sometimes they get an overly dismal prognosis and they underreport the EF. And then when they recover, the EF seems to have gotten better, but it's not really better.
yeah, got it. Yeah, okay. Thank you. Thanks for that.
Dr. Ratna, would you want to comment?
Yeah, I just want one question. This is, you had physiotherapists here, that what scales are they using for these children?
Sneha or Gauri, would you like to answer that? Sneha, you saw the child yesterday. You saw Tessa and Athampi yesterday. Sneha?
Yes, ma'am. Hello.
Hi.
Hi, Dr. Ratna, Dr. Ann. So, yesterday, what the scales I applied was, well, the child was very low functioning in terms of range of movement and strength, of course. So that's why we try to capture as much as possible. So keeping that in mind, CHOP intent and HFMSE is something that we applied, and also MFM, which categorically assesses upper limb function, transfers, as well as the distal function. So the child actually fairly did better in distal function, obviously because proximal weakness was quite high. And we also did something EK2, which assesses the wheelchair based activities. So it assesses the level of dependency. So that is also a score we've been tracking over the period of say 2-3 years now.
Thank you so much.
Thank you.
So is there any comment from anybody else? Okay, thank you so much. We overshot our time. So next, I'll put in, it's on the 17th of February. We usually have it in the finals Tuesday of every month, but this time it's going to be on the 17th February, but that's going to be newer genes in congenital myasthenia. So shall we conclude? Dr. Nidish, anybody else? Shall we conclude? Okay, good night, everybody. Thank you. A big thank you to ORDI for helping us with this platform. Thank you, Dr. Ramya, for the fantastic comprehensive talk, Dr. Himishweta, and Dr. Saravanan. Thank you.
Thank you for letting